Good afternoon, everyone. My name is Wynne Norton. I'm a program director in the Implementation Science group at the National Cancer Institute, and it's a delight to be with you today, afternoon, morning, or evening, wherever you might be joining from. And I'm going to spend the next 25-30 minutes talking about a tool that we developed with my colleagues to help plan for trials along the explanatory pragmatic continuum for implementation trials in particular. So first, I want to let you know that I have no financial relationships to disclose, and the opinions expressed herein are mine and not official positions of the NCI, the NIH, or the US federal government. So brief agenda, I'd like to go over the presentation and give you a flavor of what the tool is that we've developed, open it up for Q&A, and of course, please feel free to put in the chat questions that you have as the presentation goes on. And then, pending time and availability, walk through some different case studies that focus on the different domains for this particular tool. Online through the website, you can see one handout that's provided that includes a copy of the table, select resources, and select references. These are the 4 learning objectives as stated on the conference website as well, and really trying to better understand and introduce folks to conceptualizing implementation trials along an explanatory pragmatic continuum, and try to differentiate and better understand how these types of trials might be different for interventions and testing practices, programs, interventions, drugs, treatments, targeting individual patients in healthcare or public health settings, compared to trials, testing implementation strategies where we're trying to change the behavior largely of healthcare practitioners or providers. I'm really trying to understand and look at some case studies along the continuum, and I'll provide some description as we go through as well. So what is the explanatory pragmatic continuum? There was some discussion and presentation yesterday, as well as some from yesterday afternoon, and I'm sure throughout the rest of today and tomorrow, really trying to articulate and conceptualize different types of trials, and specifically I'm talking about randomized controlled trials here, along a continuum from explanatory to pragmatic. And explanatory trials, generally speaking, are trials that are focused on trying to better understand mechanisms. These are often termed efficacy trials, although there are some distinctions there, where the efficacy trials are really more focused on on narrowing and restricting to a particular population. And explanatory trials have different domains that they're trying to better understand the design of the trial and maximize internal validity. It's less concerned with external validity. Whereas on the other end of the continuum, we have pragmatic trials. And pragmatic trials are really conceptualized as those that are meant to inform decision makers and making in the context of healthcare providers and public health settings. They're often referred to as effectiveness trials. Again, there are some distinctions there. They're conducted in real world, so to speak, settings, and it really tries to balance a focus on internal and external validity. So maintaining rigor while also making sure that it has application to actual content areas and delivery settings outside the context of that trial. Now, the explanatory pragmatic continuum was first articulated by Schwartz and Lelouch in 1967. Of course, there have been a lot of papers written since then and presentations, and really trying to expand this type of thinking and application to trials. There are several different tools, including one that the hosts of this conference have on their website, for helping researchers try to plan for trials along this continuum. The premier or most widely used tool is the Pragmatic Explanatory Continuum Indicator Summary 2, it's version 2 from 2015 tool. This is by Kirsty Loudon and colleagues, really trying to articulate what are some of the aspects of the tools that, of the trial and some of the domains that can make it more or less explanatory or pragmatic. So you see the wheel here with 9 different domains. A score of 1 indicates, so closer to the inner circle there, indicates that the trial domain and planning for the trial domain for that particular domain is more explanatory, whereas a score of 5 would be more pragmatic. Now, just to note that you will rarely see across all domains, all 9 domains for one particular trial, you will rarely see all 1s and you'll rarely see all 5s. It's essentially meant to be on a continuum where you'll see different domains scored along that continuum. You may see something that is more explanatory, so you see more 1s and 2s, maybe a couple 3s, or more pragmatic. You see mostly 4s and 5s, also maybe a couple 3s. There are no right or wrong answers. Something can be entirely pragmatic or explanatory, but we often just refer to them as either or rather than on the continuum, just because it's a little easier to say. One of the aspects here in this tool that Kirsty Loudon and her colleagues tried to differentiate and articulate is that participants can be, for some of these domains, patients or they can be providers. However, they really only focused on a couple of the domains and didn't fully articulate and extend this tool to situations where participants are healthcare practitioners or professionals versus patients. And so what we tried to do in collaboration with those who developed PRESI-2, including Kirsty Loudon and Merrick Sworenstein, as well as with my colleague David Chambers, tried to take PRESI-2 tool and adapt it to a different level, adapt it to situations and trials where the target of the intervention is the practitioner, where you're trying to change the practitioner's behavior. And so those are the participants and the settings in which it's being conducted. And importantly, we're trying to test different strategies to change those providers' behavior, rather than trying to test interventions, practices, programs, drugs, treatments, so on and so forth, to change patient-level behavior and have an impact on health outcomes. So these are the 9 domains that we retained. You'll see some of the domains have the same name, some are different, and some of the key questions, of course, have been adapted where applicable. The same scoring criteria where 1 is more explanatory, 5 is more pragmatic. And I'll just walk through the domains here. You'll see that the eligibility is conceptualized quite similar to PRESI-2, but again, focused on healthcare professionals. So really trying to better understand to what extent are the healthcare professionals in the trial similar to those who would be in usual care. And this, again, is in the planning purposes of the trial design to match the overall intent and purpose of the trial to the actual meaning of the trial along the explanatory pragmatic continuum. Recruitment domain, again, is quite similar to PRESI-2, except we're focusing again on healthcare professionals. So what are the strategies or approaches used to recruit healthcare professionals into a particular trial compared to what might be available outside the context of that trial in usual care settings? The setting is how different the healthcare or public health settings, so hospitals, clinics, health departments, other types of organizations in which clinical and public health services are offered, in which the trial is planning to be conducted compared to usual care settings. So is it a rarefied healthcare delivery system? Are they federally qualified healthcare centers? To what extent are these relatively common and serve a large number of patients, or are they relatively distinct and have some type of different patient population that may not generalize to other particular settings? Now, implementation resources is quite different from PRESI-2 tool. And we wanted to emphasize and call attention to what resources are needed to support the delivery of the strategies. So really trying to take implementation strategies and say, what are the resources, either personnel or costs or equipment, that are needed to replicate this outside the context of a trial? And how does that compare to what's available in usual care? So, for example, are there quality improvement teams that could be delivering the strategies to providers outside the context of the trial that are already in place, which would be more pragmatic? Or would one need to hire additional individuals, allocate different funds, buy particular equipment that's not already in those particular settings? That would be on the more explanatory ends of the continuum. These are the remaining domains. Flexibility of provider-focused strategies. So again, similar to PRECI2 tool, although bumping it up a level, really trying to better articulate and understand kind of this tension between fidelity and adaptation as it focuses and applies to strategies. So if you think of flexibility in terms of that type of tension, how much variability is allowed or encouraged for how those strategies are being delivered to providers versus how it's likely to be delivered in usual care. And you have the same type of tension or comparison between fidelity and adaptation of the intervention here for domain 6, and how that intervention is being delivered by the healthcare provider to patients, and the flexibility in which it would be delivered in usual care. Data collection, primary outcome, and primary analysis are similar to PRECI2 tool, again, focused on the healthcare provider. So how different is the frequency and intensity of measurement throughout the trial compared to what would be considered routine? A score of 5, which is more pragmatic, would be data that are secondary data collection, leveraging electronic health records, for example, to examine processes and outcomes, whereas a score of 1, which would be more explanatory, would include a lot of different surveys that take a lot of time, that are encouraged participants to complete at multiple interviews, perhaps intensive qualitative data collection, mixed methods, data collection and approach. So those are examples of kind of the extreme from one end to another with respect to data collection. The primary outcome here in the PRECI2 tool would be to what extent is the trial's primary outcome important to healthcare professionals for this versus actual individuals or patients. Now, importantly, this could be similar or the same in PRECI2 versus PRECI2 provider strategies here, but really trying to better understand, is there concordance there, and how might that have an impact for the extent to which the trial is able to be conducted, and implications and application of trial results across particular settings once this trial is completed. And then finally, primary analysis, again, which is the same in PRECI2, to what extent are all data included in the analysis of the primary outcome? So a score of 1 on the explanatory end would be what's called as a per protocol analysis, where you're only assessing and including data from those participants, as in healthcare professionals, who consent to participate in the study and actually, let's say, are exposed to, for those in the experimental condition, the actual strategy, or who complete some of the data and some of the surveys and questionnaires and such, versus a score of 5, which would be pragmatic, where you use all of the data, which would be an intent to treat analytic approach with some variations and robust imputations where applicable. So how might one go about using the PRECI2 PS tool? It's really meant to, similar to PRECI2, it's meant to be used in the design phase of the trial. You're really trying to leverage this as an opportunity to be transparent about the purpose and intent and application of the trial from the beginning, and make those decisions about the particular trial and those 9 domains ahead of time to match the purpose and intent. And there are 2 aspects for PRESI 2PS that we expanded and extended from PRESI 2. One is really trying to emphasize stakeholder groups and the fact that they bring different yet complementary perspectives, and include not just the research team who can help with methodology, analytic approach, and so on, but also different stakeholder groups such as healthcare professionals, system leaders, IT experts, individuals who have a stake in this and to whom the results would apply and who would use the outcomes of this study if it were to show differences, let's say, in a particular strategy. And these individuals can help prioritize the topic area, select the outcomes, again, the provider-centered research for those particular primary outcomes, assess whether or not the strategies that are being tested would be feasible outside the context of that trial, the cost of those strategies, and the sustainability of those strategies. And the second area that we tried to emphasize above and beyond PRESI 2 is to better understand, describe, and track usual care and implementation as usual. And so we know that usual or standard care or implementation as usual is by no means usual or standard in any sense of the words. And so really trying to understand to the extent that this is the comparison to which one assesses and plans for and scores the domains, that one really needs to have a good understanding of those contexts. And that's where you bring in the stakeholder groups during, throughout, and after the trial to understand what is going on currently, how does that compare to what was planned in the trial with respect to the domains, and how might changes in that affect the interpretation of the trial at the end of the trial, depending on if usual care has changed. So really trying to, and I think the field is starting to grapple with and address the need to track usual care and implementation as usual over and throughout the course of the actual trial. So some of the key comparisons here are intervention versus strategy for PRESI 2 versus PRESI 2PS. The participants being individual patients versus individual healthcare professionals. To whom is the strategy or intervention being delivered and by whom? Again, are they research personnel who are delivering the strategies? Are they quality improvement leaders within the clinic who are already being charged with improving care? And then this tension around flexibility versus adaptation of delivery and content of the intervention compared to the delivery and content of the strategy or compilation of strategies. Future directions for PRESI 2PS, as with the PRESI 2 tool, really trying to test the reliability and validity of the tool, apply prospectively, and then as well as retrospectively, although there are some methodological limitations to applying retrospectively, assessing changes in domains that may occur naturally over time and how that may have implications for the interpretation of the trial and the application of the trial results, a repository of case studies that can help better understand and use for training purposes, and get a snapshot of the field in terms of, are these strategies more on the explanatory end, the pragmatic end, where might we have saturation and focus on a different end of the continuum or in the middle relative to what we already have. And then, of course, revisions to the PRESI 2PS tool. And we look forward to receiving your feedback and input and ways in which we might and should revise the tool moving forward. I will pause there for questions and comments. Let me look through the chat. Russ's question here, which looks like the first one. Oh, good. Yes. I'm assuming, yeah.
Yeah, it's just a quick one about applying this to, if you will, higher levels, like if it's a real multi-level intervention and you're focusing not only on providers or practitioners, but also some changes at higher levels, like in the broader organization or the community, or maybe even a policy intervention. Will this work for us? Do we have people do it twice at the other level? Do we wait for the new Praxis 3?
Yeah, it's a great question. And we really grappled and tried and struggled with this. We were trying to put kind of parameters around, are we talking about provider focused strategies only? Oftentimes, if not, well, often the strategies are focused at those multiple levels, as you know. We tried to restrict it to provider in comparison to patients, although recognizing the importance of that. So we've thought about maybe there are 2 wheels that could be coded, maybe 3. Again, it gets a little unwieldy at a certain point in time. But your point is very well taken. I think they are in discussions around PRESI 3 and trying to understand how that might play a role here. I think certainly it could be combined and operationalized that way, but again, look forward to you using the tool and adapting it and really trying to address some of those issues that you brought up.
Well, not seeing anything else, Wynne, I'm just wondering if you have thoughts or tips about training people for the use. You talked about the reliability and things, but training teams to use it. Just are there lessons learned or things to watch out for or expect when you're training people that don't know about it to use it?
Yeah, that's a great question. I think for this version, we tried to expand a little bit and drive that point home in terms of you really need, and it's a nice opportunity to engage stakeholders from the beginning. So, you know, consistent with community-based participatory research principles and really the stakeholder engagement. So that is one thing that I would suggest folks consider, kind of above and beyond, and bringing in those different stakeholder groups that aren't just the ones who are participating in the trial, but those to which one, if you're doing a more pragmatic trial, to which the results are intended to be applied and used and get their perspective on what might be feasible. So bringing them to the table, and certainly I think there is an opportunity to try to develop those training packages that are a little more expansive, rather than the ones that have been traditionally in use, which are targeted for researchers or limited to researchers usually. There are some online courses on pragmatic RCTs that are available that aren't just limited to the PRESI 2 tool. And there are a lot of resources out there, as you guys have, of course, the ebook on your website, really trying to conceptualize trials along this continuum and leverage different tools. Now, PRESI 2 and PRESI 2PS are just 2 of several different tools available. I think the PRESI 2, of course, is the one most often used in the field, although I know there are others that are being developed too.
Wynne, could you talk a little bit more about these kind of 2 flexibility components? I get a lot of questions about what do they mean? Is flexibility bad? Can you talk about that? Maybe go to the figure and talk through that a bit.
Yeah, so the flexibility here, we have it at 2 levels. So flexibility of intervention is the same as in PRESI 2. So really trying to better understand, you know, is this an intervention to which you need 100% fidelity, you know, on an extreme level here, and you can't have any variability in how it's delivered. Or is it one that you encourage folks to adapt to the context, to the patients, to the providers, to the delivery system, to better match that context and fit to encourage actual adoption and appropriate use? Flexibility of provider strategies is the same again, but bumped up a level. So to what extent are those strategies oftentimes to date that are being delivered by research teams who are charged with doing that within the trial? Can you have some flexibility in how frequently those strategies are delivered? How much time is being used for technical assistance? Is it something where you can have an opt-in or an opt-out for particular strategies and the healthcare professionals engage with those? So you can think about it as kind of these core components versus peripheral components of strategies, just like you do for different interventions. Now, it's not to say that 100% fidelity is bad and 100% adaptation is good. Again, it really depends on that particular intervention and the strategies and what one expects for the outcomes. And again, relative to what is being done in usual care settings.
And so this is a scale from 1 to 5. What if everything's a 3? What kind of trial is this?
It is a balanced Prag-Explan. I'm not sure. It's difficult, I think, just the terminology here, because there isn't a good, midway, and you're often not, like I said, not going to see all 5s and all 1s. It's a good question, and I think we would want to have examples of that to help calibrate what the case studies look like, to compare them and contrast them. I'm not sure that for PRECE 2 I've ever seen an all 3s or all 1s or 5s, 2s or 4s. And that just might be where, if you get all 3s, where the state of the science is. Again, to emphasize that explanatory isn't bad and pragmatic isn't good per se. It's really the objective and being transparent around what the actual purpose and intent is, and to match the trial design to that. So it might be the case that they're, trying to better understand mechanisms, but also more pragmatic real world application, which is where you might see more scores of 3 for these 9 domains.
Anyone else have questions? You can all take yourself off mute, turn your video on if you have a question.
I don't know if that's good or bad, but I'm happy to answer questions if folks have them afterwards. Please feel free to email me, of course, if you'd like additional information or would like to chat. Let's say if you'd like to consider using this in a grant application or whatnot, as well as if you're just using it for a trial. We really would like your feedback and input on how we can improve this over time to make it really a useful tool and not just an exercise to be done that doesn't really have application and doesn't ideally try to improve the design of the trial, all in service of trying to get to a place where we can design trials that have application and are relevant to those who would actually use the trial outcomes after it's been completed.
It's like Marie has a question.
Yeah, I guess it seems as if, can you turn yours down? Thanks. It seems as if you are really focused on using this in the design part. Do you recommend reviewing it then throughout the process of doing the trial as well? And do you have any other examples that we can go to just to look at how this is being applied?
Yeah, absolutely. So with respect to the examples, I'm happy to send a couple links of articles. There's one that our team at NIH did that was kind of a baseline type of assessment, really coding a protocol that had been written and actually pilot testing. And then a year later, some of the changes that had been made to the trial design based on that and moving forward with the full trial. So looking at those 2 time points and what has changed over time. I think, you know, it's initially has and was intended to be developed for the design phase, but is increasingly, as you point out, really necessary for understanding, you know, what if eligibility needs to change because you're not enrolling enough participants, or recruitment strategies need to change as a function of how the trial unfolds, or other aspects need to change based on what your stakeholders information that they're providing you, how usual care is changing rapidly. So really trying to tease that apart. And maybe there are different time points that are scheduled based on how the trial unfolds at which one needs to reassess this.
And there's one other question in here. Has this been used in settings other than primary care, like with schools at this point?
Yeah, you know, I'm not sure if it's been used in schools. I think that it certainly has application there. The PRESI2 website has, if you, I think you need to set up a login information and username, but it has a compendium of over 500 registered clinical trials in a lot of different settings. And I believe there is a relatively recent review of what types of trials this tool, PRESI2, has been used. So it has been used far beyond primary care. I'm not aware that it's been used in schools, but I think that's an excellent opportunity to expand this. And it's, again, not necessarily limited to health, but has been developed in service of trying to make the results of trials more equitable and applicable beyond what has traditionally been very internally consistent validity focused versus a balance of internal validity and external validity.
Well, thank you, everyone. It's time to transition to the next breakout session. And we'll have Roger Kessler talking next about patient-reported outcomes measures. So if you want to stay here for that, you're in the right place.
Thank you all. Really appreciate it. And again, feel free to contact me if you have questions or comments.